perception in the outside world. There is a great success in the works we do, and in the forthcoming days, we are in bone marrow transplantation and in leukemia treatment. We have 94% full success rates in the treatment of leukemia, and we have shown this in our publications, and we are going to achieve 100%. Is this achievable? We are after this target. We have a great scientific team, and of course I think we are going to be giving the good news of 100% treatment success. And today I'd like to thank those who have exerted efforts to hold this meeting, to Congress. We don't have a great many sponsors, and we are just doing it on our own. And so this symposium is done with the efforts of our friends, and I think that this will shed a light on the science. And of course, in the forthcoming days, we will have many international events and congresses with a greater participation. We are pleased to see you among us, and I hope that this is going to be a beneficial meeting for all of you. Thank you very much, Dr. Üstünözer. For the next opening remarks, the pediatric coordinator, Professor Dr. Emin Kürekçi, to the floor. Thank you. Good morning, distinguished colleagues, distinguished nurses, and our personnel, esteemed personnel, and esteemed students. Today, you are here in the second International Cancer and Life Symposium. I would like to thank you for your participation, and we are honored for your presence in this conference. As you know, cancer has a great impact on our lives, and if you are going to give the data, we have 240,000 new cancer patients in our country, and of course we know that it has a bad prognosis with the adults, and we need to just put forward the mechanisms of this disease, and to battle against this disease requires a great infrastructure and a scientific accumulation of information. And we have, it's all about education, and education is a preliminary prerequisite of this fight against this disease. And as Seneca mentioned, you know, Seneca is a Roman philosopher and a diplomat who lived in the 2nd century, and he said, homines dum docent discount. What he says was, human beings learn while teaching. And so the E is education. And we have been always, together with the scientists, together with our colleagues, we are both teaching and learning at the same time throughout this process. That's why E, which means education, is very important. Of course, Lösev is working for the cancer patients, and we are also doing scientific research in our hospital. We are working mainly on food and and cancer, and we have had many scientific publications up until now. Maybe you have heard it before. Omnis cellula e cellula, all cells stem from one cell, and they do then develop and they become tissue. And the pathologist Bischoff has discovered this, and we are still working on the cells. And under the microscope, the cells, for the first time they were discovered. We just wanted to understand the working mechanism of the cell. And this is a very tiny but a huge factory. If you can really solve the working mechanism of cell, then you can just really understand the mechanisms of different diseases. And cancer is the most important one of these diseases, because if you know the cell, if you know how it dismantles and how it is disrupted, and if you understand the anomalies and how you can just stop these anomalies with which mechanisms, of course this will be a step forward, because you, the students and the scientists, are trying to understand the working mechanism of the cells. And today and tomorrow we will be discussing about the cell mechanisms and the molecular disruption of these cell mechanisms, and also the genetic patterns of the cells. And we want to know where the world is headed in terms of understanding these mechanisms. And of course we will have great many information that we are going to learn from these 2-day symposium. And of course we have some hot agenda items, and they will be giving us lectures, and we will just shed a light on the dark side of this affair. And of course we would like to share all this information and disseminate the information to the masses at the same time. Therefore your presence is very valuable for us here, and I hope that this is going to be a very good conference. And I'd like to thank you once again for your participation and for your support, and I'd like to celebrate all of us again, and I hope that this will be a beneficial symposium for everyone. Thank you. Thank you very much, Dr. Emin Kürekçi. And now I would like to invite the General Coordinator of Healthcare Services of LÖSANTE, Fatoş Gürbüz, to the floor. Good morning, our chairperson, our colleagues, our doctors, the personnel of LÖSANTE, and our guests. I'd like to once again welcome you. Our nursing is quite different. When our friends join us, when they graduate, they graduate from the nursing academies, and of course they need to improve themselves constantly. When they come to us to work, and they receive great training, because oncology and pediatrics nursery is not really easy. We have a training for 3 days every week, and I hope that when we become a university as Lösev Kent University, I think this will be much easier. We have trained thousands of nurses, and they went to the state hospitals and to private hospitals, and they feel really strong because of the training they received. And I think you cannot skip training, you have to follow the current publications, especially because I know and I was trained in the private sector. They only expect you to work. They only expect you to work constantly. Here, it's a difference. To invite also Nushan Karakchi from the nursing services of Lösev. Thank you. Good morning. I think due to a transportation problem, there are some people missing in the symposium. We don't want to make you wait any longer. I'd like to thank to the organizing committee of this international symposium. I'd like to invite, I'd like to thank to Lösev board of directors, to the chair of board of directors, and this is the day of the nurses, and I think this will be beneficial for our nurses. Let's open the first session now. Hematology, as the hematology oncology nurses, how can we become more powerful? I would like to invite Fatma Gündoğdu from Karatay University. Thank you very much.
Ses geliyor herhalde. Tamam.
I think you can hear my voice. Thank you. Distinguished Chair of Board of Directors, distinguished colleagues, I'm really honored to be here and to be a part of this event because the great efforts have been exerted. And thank you very much for inviting me and giving me this opportunity to address to this August Hall. Hematology and oncology nurses, and how can we just empower them, and we've been working towards this end, how we can empower our nurses. And you can see the presentation plan here. Why do we need to be empowered? This is the first question that we need to ask. And I think you will see what we need to do. There's great scientific advance, and we need to learn anything and everything about the scientific information. And of course, what we need to do is to be side by side with the patient. They need to trust you, and of course we need to be empowered, and not for us, but we need to be empowered because of the diagnosis of the cancer. We need to end the suffering of these patients, and because we need to end this problem, and I think we need to decrease the burden on the shoulders of the patients. And of course, if you see an oncology nurse in the board of directors, or if you see a nurse in the decision-making processes of the Ministry of Health, and if you see a nurse right next to the patient, I think this is empowerment. And if we do this, and of course we could just finish the lecture here, but those who have struggled up until now, both internationally and in the national level, the oncology, I think this we cannot do this to cut short what we have done so far and what we can do in the future. So I'd like to just present them the possibilities here. And let's look at the history of the oncology nursing in the 1940s. The oncology nursery has become a field of expertise, but unfortunately, since the obligations and the duties of the nurses working in the oncology
1947'de Columbia Üniversitesi'nde
in the Columbia University, the master's degree were presented in the Columbia University, but I will be talking about the history of the nursery oncology nursing, and it has started in the 1980s, and now oncology master's degrees continue in today's Turkey, and in the 1960s, with the lymphoma patients, we have seen after the drug research is started, and we see thinking about how we can we have they are together with us, the executive board member of EONS. We have some great participants from EONS as well. We have been represented in EONS, and we are really proud, and I think that we will have the chance to meet the EON members from foreign countries. And when you look at Turkey in 1999, during the 1990s, the awareness started to increase. In 1989, Marianne Fredericks, the ICNC chairperson, came to Turkey, and Leman Birol has passed away, unfortunately, and she wanted the participation of our professor to the London conference, and then Professor Leman established the oncology nursing in 1989, together with our friends from the clinic. And right afterwards, we started giving trainings on in the provincial level in Kayseri, Izmir, Istanbul, and we just wanted to further the oncology nurses. And after 10 years, for the first time in Dokuz University, we started giving master's degrees in oncology nurses, and this didn't have any clinical value at the beginning, but now there is great interest in these master's programs. But when you talk about master programs, when you just graduate from master's program, they don't have a title when they come to work in the clinics. And so it's not really high on demand.
iyi olduğu ülkelere baktığımızda aslında uzman ileri düzey onkoloji hemşiresi dediğimizde klinik alandan
Well, for 2 years, of course, we don't have such an entitlement. We have our master's degree programs, but it's not used efficiently. When we come to the year 2003, oncology nursing started with the chemotherapy applications. And of course, in the safety protocols, our friends and our colleagues were talking about the problems, and together with the Oncology Nursing Association, there was a scientific research about the level N90 levels in the urines of the nurses, and
yüksek olduğu görüldüğünde de bakanlıkla ayrıca onkoloji hemşireliği
We started to work on a guideline and in 2004 we had this guideline, but this was not turned into a regulation. Yes, we have the guide, but it should have a higher sanction power, and we should turn that into regulation. So we are lagging behind. In 2005 we had the first chemotherapy nursing certificate, and I was a secretary at this association at our society, and we had a protocol with the Ministry of Health, and this was the second certificate program of nursing. And for 10 years we held this certificate program in oncology for oncology nurses, and in 2015 with the changes in the certificates regulation, we had a new system. This certificate, the program was turned into a 3-week program from 1 week program. It was a 1 week program, and then we started to use the regulation. It is now a certificate program which is made by the ministry, and all the hospitals can give this certificates when they meet the necessary criteria. And so we decided to have a distance learning, at least for the theoretical part, but now the discussions are still ongoing. As you all know, we are lacking in personnel, and we have a heavy burden of workloads, and we need to go to a different province to have this training. It is a significant cost, and it is also a time waste. So we decided that maybe we could provide this training online, and those such hospitals can be in the responsibility of those people who have been certified. So I believe that there will be some changes, and starting from 1989, we had two translations of textbooks. They were great books, and of course the information is not up to date now, but one of them was ICNC, Oncological Nurses book, and the other one was International Cancer Organization book, and we translated them. And then we had consensus approach. It was a great unification for us, and in 2011 we defined the responsibilities, duties of the oncology nurses, and now everyone is using this. It is also in the legislation, in the regulation of the Ministry of Health. So we are using these books. So what are the problems? What are the current problems? In order to have this distant learning, we need to work really hard, and also our personal rights are another issue. There are some demands from our colleagues in the oncology departments, but we've been working for about 15 years, but we are not able to see any improvement in terms of rights. We have RICAM project by European oncology nurses, and we are trying to make them more visible. And DIONS is an advocacy working group, and they prepared an index by making interviews with 37 countries, and you can see the Cancer Nursing Index 2020. The data is collected but is not published, but we have the 2020 data published. This is why I'm sharing this with you, and you can see the scoring here in accordance with the Cancer Nursing Index, and they looked at the occupational safety recognition, working conditions, and effective workforce. their impact on workforce. When we make comparison, these darker green countries are better, in a better condition. The western part of the Europe is in a better situation, and as the shade of the green gets paler, and we can see that things are not that good. We have the 49 to 70 green, and Turkey this is Turkey's color. And what is the reason for this lower grade, low score? Actually, we do have trainings, and we need. These kind of developments are increasing our score, but we don't have advanced level oncology program, and EON's core curriculum program is not recognized by the ministry, and they are not organizing trainings with regards to them, and they don't have the oncology nursing definition and the regulation of the ministry, and so we see that the scores are getting lowered, and these scores can be improved, of course. So this is a meta-analysis, and we are looking at there is no compulsory education legislation, and there is a lack of continuous education opportunities. So we need continuous education, and we don't have any compulsory training on legislation. For example, if an institution is really good, like LÖSANTE, they attach great importance to the training. They have their orientation programs, and they have their continuous education. And the education should be compulsory, and we don't have a certain curriculum, and the nurses cannot find enough time for their trainings. And for this reason, we need to work on them. Oncology nurses should have a certain certain abilities. It is really important to open a blood vein or just check the blood pressure, but it's not like that. The ability is not just that. This is not a robot you are interacting with. There are patients, they have feelings, they have emotions, so every word or your every move will affect those patients in a different way. If you are competent in your field, if you know what is needed to be known in your own field, it is a better reflection, it causes a better reflection on the patients. So what are the important things about education? First, the most important, when we think about the most important training, communication gets the highest score, 8 out of 10. Empathy and active listening are important, and if we improve their competency in the field of empathy and active listening, things will get better. Coping is in the second line, and then there's a problem about limited number of workers, employers. There are some hard patients, there are some uncertainties. So conflict resolution is important. So how they're going to cope with stressful conditions. They should have some abilities about this. We should improve their abilities about coping. And the technical skills are also important. I'm not talking about just checking the blood pressure. We should strengthen the patient and the family, and how are they going to use this knowledge, use their knowledge to inform the patients and their families, how they're going to have a self-care management for patients and family, and pain and symptom management. So when we do this, we will have a self-learning possibility for the oncology nurses. So when they try to learn better, so this is actually an important method. Please, can you please wrap it up? You just have 1 more minute. I will skip these parts. You can find this in my presentation. Physical, structural improvements and mental health improvements in the working place, working environment are important. Sometimes we do not think about these things, but we had studies with 8 different cancer centers, and the doctors and nurses. Okay, it can stay there if you like. You can use it. Burnout, coping with burnout is another issue. In the afternoon session, we will have another meeting, another presentation. I wish that you don't miss it. And it is quite widespread. Its percentage is 30%. Maybe you say that it is okay, this can happen, but this is causing low personal performance in 35% of the nurses. So coping mechanisms, coping activities are really important. This slide is summarizing everything. How can we strengthen the oncology nurses? And we need to make the oncology nurses leaders. And leadership is a skill, is an ability, and it is a competency. And how can they gain this competency is important. We need to organize some activities towards it. And leaders of oncology nurses should take part in policy making processes, decision making processes. They can take part in the councils, committees, and the education, continuous education and counseling are important. And leadership positions in cancer care settings should be supported. And they should have this leadership possibility, opportunity, and autonomy should be increased. If you give the responsibility and if you don't give them the authority, then there is a problem. So we need to give them the authority too, and we should have the necessary legislation, regulations, and we are working towards this as the Oncology Nurses Association. And now the expert nurses is now defined, but in clinics we cannot see that they are appointed. So this should be done immediately. So what is the cost of doing these things? Actually, we have the 62 cancer centers identified by NCI, and they conducted a study, and according to this study, there are 23 projects involving nursing education. Then they have been carried out in low and middle income countries, and their budget was lower than $200,000 US. And normally their budgets are $1 million, so this percentage is really low. And so we can make use of these kind of projects to strengthen the oncology nurses. And one of the most important strengthening is individual strengthening. This is a study conducted, and it's about the meaning of being, what it means to be an oncology nurse. They say that investing to make a difference. So investing to making a difference, for example, going to trainings or attending these kind of symposiums. So this is investing to make a difference. So we need to work together, and also we need to invest in ourselves personally. It is really important. And thank you very much for your attention. We would like to thank Fatma Gündoğdu for your presentation. We have 7 minutes. We can have some questions. I will say one thing. I think we need an oncology nurse among the decision makers. To sum up, we can say that among the decision makers, we should have someone with a background who has the experience in the field of oncology nursing, so we can be stronger. So this was my contribution. If there is any questions, we can receive the question. If not, we will continue with the next session. Thank you very much. Student Bey was also telling about the past. We are telling about the similar years. We had the Department of Nursing Services, and when we were focusing on certificate program or guidelines, and we were working together with this head of department, it was Department of the Nursing Services. But now we don't have this department, and the Association for Turkish Nurses is now working on this, but hopefully we have a unit which is representing the nurses. It would be great. I think the chair of the Turkish Nurses Society is now here, and we have a committee for strengthening our jobs, our occupation. I think Emin Bey would like to say something. The floor is yours. I am sure that it is a must to have this system in the Ministry. Oncology nurses now being improved, and the certificate programs are lagging behind, and then we don't have the programs, we don't have plans for those certificate programs, so we should have a certain system for it. Like it happens every 6 months, and it takes 6 days or 5 days, so these should be designated, and of course with the support of contribution of your society, we can have something. So we are waiting for it to open, for a certificate program to open, and we wait for 2 years once, and then it opens 6 months later. So ministry is not taking this seriously, in my opinion. What do you think about this? So this is why I say that among decision makers, should there be a nurse, an oncological nurse. It is really hard to explain them. After the pandemic, when the lockdown was cancelled, we visited the ministry, and we had 3 other meetings, so we are not able to have any other improvements. So when we go there, they have always a positive attitude, but we believe that there will be some solution for this problem, but we're still working. But this means that we need to work on this, we need to continue struggling. And when the regulation was changed, we had to take a 2-3 year break. We used to have 6 months, have these certificate programs every 6 months, but we need to continue working on it. But because of this new regulation, we had to take a break of 2-3 years in order to have this regulation about oncology nursing. So these kind of problems may happen, but I believe that we will resolve all this issue altogether. So you said that you're planning to have this online certificate programs in an online form. How effective do you think it is going to be? Because due to pandemic, we started to use online training, but yes, they have a positive contribution, but especially in nursing trainings, I don't know how much effective they could be. Ministry is now responsible for the regulation, and we are working together, and We thought that this could be online, maybe not the practical one, of course, practical lessons. Sometimes they have problems in going to different provinces, so we need to have a planning, and this is what we recommend, this is what we suggest, so they have a positive approach, but we didn't have any feedback. And they said that let's have a working group and do it. Oh, we don't say that it should be totally online. I wanted to elaborate on this. Yes, of course, one of the most important problems for us is the fact that science, politics is coming before science, so we are paying the price as all human beings. We need to give the priority to science, so this was all from my side. Thank you. Let's have another question. Hello everyone, thank you very much for this. I just retired from Athens University. I'm an oncological nurse, pediatrics oncological nurse. I will have a contribution. This is not a question. Certificate programs are really important, but as someone coming from the clinic, as you said, we are a developing country, and these certification programs prices are not covered by the hospitals all the time, because the hospitals do not realize the importance of this, and the regulations should include this too. They say that they should have, the regulation says that the institutions should have this or that much, that many nurses, but we should have some thing about this too, because when things are not written, things are not improving. The number of patients per nurses is increasing. People's quality, the quality of healthcare services, the certification programs should be increased, but I know the people are not able to attend to these courses because of the cost, and we are talking about investing in ourselves, but in developing countries, as you know, we are giving priority to our financial management, and so there should be some changes about this. Maybe it should be compulsory. As they are taking the certificate and sending it to someplace else, so there should be a position, and they should work in this way. So you are talking about a really important issue, and we are working together with the ministry for the regulation. Chemotherapy units are important because there is outpatient chemotherapy in those units, and we studied for that, but on our website of oncology nurses, it is still a guideline, it is not a regulation yet, and we will make use of this regulation. We have very limited time. I will give the final floor to Sevgi. Thank you. I don't want to talk too much, but in short, I will say one thing. Thank you very much. This was a great presentation. Strengthening the nurses is really important, and oncology nurses specifically is really important. Actually, the world of nurses is doing this for many years, all our colleagues, and we have the greatest support from the faculties of medicine, as we are working together, but we're not strong enough yet. There are some factors which are strengthening for us. One of them was training, and we have our faculties. Now we did have institutes, and we have faculties. And what is the missing part? You said you talked about the policies. Yes, policies are an important issue. We need to have someone in those board councils with the background of the oncological nurses, and we did even have a member of parliament with the background of nursing, but we didn't see any improvement. And for many years, I've fought against all these problems. We are not able to have improvements because the nurses do not feel valuable themselves. There are many factors to that, and there are their personal differences, and we have these kind of colleagues among us. They're really working really hard, and I always tell this nurses that you are really important. If you exist, as long as you exist, there will be care for the patient, and we need to accept this. We need to understand this. We need to understand this. We are in the caring, and of course we should invest in ourselves. And oncological nurses are actually the nurses which are the stronger in different fields. And there is also the geriatrics patient, the nurses. But it is not as improved as oncological nurses, because in our country everything is going really slower, because we are trying to make changes personally. And Turkish Society of Nurses is working alone. Everything is going really slowly, and if you work really hard, you are improving. There will be obstacles all the time, but I can say that to the oncology nurses, you're really valuable. Please know that, be aware of that, and you don't have to protect your existence. You already exist, and love yourselves, love your patients, and it is really important to have the support of the patients and the families of them. Good care, quality care will bring that to us. You said that the communication has the score out of 8 out of 10. The patient said that I need to hear good morning. There are some nurses who are not saying even this. So saying good morning, it will strengthen us. Thank you. Thank you, Fatma Gündoğdu. We need to continue with the next speech. Okay, let's hear your question. Thank you very much for those who made contribution. I am working in Afyon Health Sciences University and hematology and oncology expert, pediatrics hematology and oncology expert. And the role of nurses is really important in their care, and the reason for that is really important, because the nurses should be educated, trained, and one of the most important problem for the nurses to go and have a certificate. Maybe your association can have a cooperation with universities, and with the support of the universities, academicians, can we have the institute trainings. And because there is a problem about accommodation, transportation, they want to attend these kind of meetings, but we can have on-site trainings, and with this on-site institute trainings, we can have a better approach. I would like to ask this. Thank you very much. This certificate program can be done in hospitals. This is the way we present to the ministry, but the ministry give the permit. But what you said is really important. We can do something about this too, and we have meetings with different hospitals and universities, and we can send trainers to those institutions or organizations, because we are also making our applications. So thank you very much. And İzmir University wanted to have this training in on-site training, but there was a change in the regulation, and then we had to wait for some time, you know. Thank you.
Var olan bir gerçek.
Well, this is the reality that we cannot really ignore. And I know that we are going to learn a lot from this meeting, and this is going to be very beneficial. We have exceeded our time, and now I'd like to invite the second speaker, Nevziye Semerci from Koç University. And she will be talking about how we can attract the youth to oncology nursing. Well, you got 20 minutes and we've got 10 minutes of discussion. Well, I will wrap up, believe me, and I would like to thank to the scientific committee and the organization committee, and I am working as a PhD in Koç University. I was always curious about LÖSANTE, and I knew that it was about the caring of children, and of course we see that they are giving care to both healthy and other kids as well. As a young oncology nurse, what I have done so far and what I have benefited from, these are the questions that I'd like to answer. I graduated in 2013, and then I worked in intensive care unit in reanimation, and I just wanted to work with children. We are adults in intensive care units, and I just wanted to work with kids. And my mentors have told me that I should become a trainer, and I started working in the Trakya University of Thrace, and I was just wondering which field I need to specialize, and my professor sent me to the child oncology, and I didn't know what to do at the beginning, and the kids were playing, and one of them just said, "You've got nice braids," and I started crying because the child just wanted me to have braids, and I thought that this could be the only place that I need to be, and I just wanted to work with children. Then I started researching. Tuba, my professor said, we have an association, Oncology Nursing Association, and I became a member to this association, and I was introduced with EONS. And we have had some subcommittee works, and I started working actively, and I just wanted to contribute to the trainings of oncology nurses, and we have held many meetings and conferences. And I will talk about EONS and CEOP. I've got experience with these. Then there's no any conflict of interest. I think the oncology nursing group should have should have a group like EOS, and we need new leaders working in this field. And of course, they will have a say in the management. They will have, they will become a part of the decision-making processes, and we will become, they will become leaders. And we have 38 members from 17 countries, and we have Hazal and myself from Turkey. But my term is almost over. You need to have an experience of 7 years of oncology nursing, and of course, if you are a member to the oncology nursing members, and you are automatically a member of EONS as well. And I think you could just make use of all the advantages brought to you by EONS. EONS has 4 groups: EONS Communication Working Group, Advocacy Group, Research Group, and Education Group. And the 5th one is the Young Oncology Nurses. But in each of them, they have the Young Oncology Nurses. So, as the oncology nurses, what do we do in terms of meeting the needs of the young oncology nurses? You know, we have empowerment issues, we have AI, and how we can just integrate AI to the oncology nursing. So we have symposiums, as you can see here. We just wanted to update our information, and we would like to contribute to the education of the young nurses, as we could send a questionnaire to the young nurses, and we just wanted to know in which areas they need training. So these are some of the webinars.
Sonrasında webinarlarla beraber,
and of course we have blogs. We have now started a regular YNC blog full of advice and inspiration on how to move your career forward and build the future of cancer nursing in your country. And we have also bulletins, monthly bulletins, whether there are new trainings, whether there are new publications and awards and grants to be granted to the young oncology nurses. And these are some of the links. We just provide these publications. We just publish them, we search them, and then you can just easily have access to the new manuals, new researches, or new guidelines. There are webinars as well, as this is early breast cancer mini-series webinars, and you could just participate to the trainings. And Gülcan will be talking about the education opportunities, and of course about the early management of early breast cancer. And of course these are not only online. We have Twitter chats, and we are using the social media channels. Then there are campaigns. In order to contribute to the campaigns, we just try to attract the young oncology nurses. Of course, there are some how we can attract these oncology nurses, and you need to give them specialized training. Specialized training is a great problem. Why are we not like the other nurses? Why is our training duration is short? And because the trainings are given for 6 months, and in Africa it's 3 months. Why do we have only 3 weeks of training? Because it's theoretically, and then we have the practices as well. But of course, when you go to the foreign countries, if you are going to start as oncology nursing, you need to receive a training for 1 year, and And of course, there are frameworks. And I think as the oncology nurses, since the Ministry of Health has not yet permitted, but there are the frameworks, the career pathways, and we have also the education opportunities. Well, it's 1,000 euro to attend to the conference. And if the nurse is under the age of 35, if you are a master's student, and if the congress is 1,000 euros, then the young nurses could just only pay 97 euros. Of course, there are a lot of congresses for oncology nurses. And of course, you could have maybe 3 or 4 people that you can send to these congresses, and I think it's going to become more attractive. And about the research, sometimes you might just lack some research activities, but when you just start your clinical practices, of course, it lacks when you are working in the clinics. In EONS, we have 4 different research workshops, and for my PhD dissertation I have attended to the second one. If you have a topic, if you have a study topic, then you can just apply for it, and there are the methods how you can write down the dissertation. Until recently, when you go to the congress is held in different countries every year. I attended to the one in Greece. Your transportation, your flights are free of charge. You stay in a hotel in Athens. And about your research dissertation, you receive training. This year, I think the flight fare is not reimbursed. I will not go over these because Gülcan will be talking about this certification program. There are guidelines. There are also the Turkish translation of these websites. This year, as I have mentioned about research proposal workshops, this was held in Barcelona, and this is one of the workshops that I have attended to. And of course, if you are going to have a research and if you don't have the necessary funds, EONS can give you this. And and maybe the Oncology Nurses Association in Turkey could just give some grants to the researchers, and you will receive around 2.5 thousand euros for a year. I think you could also apply for grants from EONS. For 2 years, the grants have been the recipients of the grants are from Turkey, and one of my PhD students have come, and of course we are working actively in the groups, and you can just stay in a group for only 2 years, and you could have 3 terms of 2 years, then maximum you could stay for 6 years. And of course, the management systems are working well as well. We have chosen a president, and the co-chairs are working together. The previous chair and the existing chair, the future chair works together. I think we can. We will do the same thing, and we will continue to do so in the future. We have fellowships as well. Just like the Erasmus mobility movements, you could just go to the hospitals in the foreign countries, in Italy, in Portugal, not only for the pediatric oncology nurses, and you could just stay there minimum 1 week and maximum 2 months. And of course we can do it. When I see LÖSANTE, why a nurse from Diyarbakir or Gaziantep provinces could come to the American hospital, to LÖSANTE, to different hospitals. I think in order to create motivation and development, I think we could do all these. I've mentioned about the congresses, and we have scholarships as well. You could just send your application and you could just send your research, and what this will contribute. And of course they do accept 20 applications, and if you are among the 20, and they are going to give you 500 euros, and you can just spend it for transportation. This is done with EONS, and CIOP also does this internationally. And we have sent two of my colleagues together, me and my colleagues, we have sent the applications, and you don't need to know English, because some people are really not hesitant because of the language barrier. The main idea of CIOP is the development of development of nurses coming from low-income and middle-income countries. The trainings are free of charge. There are scholarships and projects that you can attend to. And if you are living in a low-income country or a middle-income country, they do prioritize your applications. The main objective of CIOP is to develop the standards of nursing in the low-income and middle-income countries. And of course we have I don't know whether I think we are in a good place in terms of meeting the European standards of oncology nursing. And CIOP, of course, we have project awards up to £10,000, and you can do your application from here. And today is the Pediatric Oncology Nurses Day, globally is celebrated, and I'd like to celebrate your Nursing Day. Thank you very much. I'd like to thank you, Ms. Samerci. With your energy, with your youth, I think you will be a role model whom will attract the youngsters. Are there any questions for the presentation? Please, you have the floor. Well, of course, with this opportunity, I'd like to thank everyone who have exerted effort for the holding of this conference, and I'm listening curiously to the presentations. And I'm a senior educator, I'm a senior professor, and it's been 50 years I've been working in this field. But of course, about these legislations and legalities, these are not really easy. And within the context of acquis communautaire, there have been works in order to update and upgrade the education levels. And we have worked with the Speaker of the Turkish Grand National Assembly. We have worked in different committees in order to elevate our profession. But of course, when you talk about this association, you need to talk about the legalities and regulation as well, because this cannot be done without the legal framework, and of course the legal infrastructure should be suitable, and And I do attach a great importance to this symposium. I've read it in a book from Muazzez İlmiye. In order to have a meaningful life, what do you need to do? And there is a Sumerian proverb: if you know, why don't you teach? So I think this is how it should go. There will be things that we learn, but when you learn, you have to teach. You have to disseminate the knowledge, and you have to contribute to the lives of the individuals all around the country. Thank you very much. Fethiye is our mentor from Hacettepe University, and with their vision, we just plan for the future, and I hope that the youth will benefit from her teachings. Any other questions? I think none. And I'd like to Miss Fatma, yes. Thank you very much, Remziye. We have received the messages as the association. Of course, we need to just discuss amongst ourselves. And Remziye is giving a lot of contribution, and she is the voice in the international arena. And thank you very much once again. And I think we need to also form a young group as well. And it's very meaningful to see Fethiye, Professor Fethiye. I was 16 years old. I was in the Health College of Hacettepe University. Then I became a nursing student. During the surgical internship, Fethiye was bringing in the undergraduates, and Fethiye just encouraged me to participate in all these studies. And I think this the case discussions are still in my mind, and I'd like to thank her once again. And Remziye, once again, I'd like to thank you for your contribution. And I think there are no other questions. And thank you very much for your contribution. Before closing the first session, I'd like to have you, Ms. Gündoğdu, to the floor for the participation. We will just give you a participation certificate. Thank you very much.
Değerli konuklar, sempozyumumuzun ilk oturumuna burada bir ara verelim. 15 dakikalık kahve molasının ardından
Let's give a coffee break for 15 minutes.
yapmak üzere Gazi Üniversitesi'nden Sayın Profesör Doktor Ebru Törüner ve Başkent Üniversitesi öğretim üyesi Sayın Ayşe Ay'ı sahneye davet ediyorum.
Sayın konuklarımız,
Distinguished guests, distinguished professors, I'd like to welcome you once again. It's been a great joy and honor to be amongst you. And I'd like to thank those who have exerted effort for the realization of this conference. And I'd like to just start with the second session. Our subject is symptom management and new applications, and I'd like to invite Professor Dr. Şengül Yaman Sözbür from Gazi University. She is going to be presenting using technology in symptom management of oncology patients. Thank you very much.
Günaydınlar herkese.
Good morning, everyone. I'd like to welcome you again, and I hope that you will have a great day. And I see that there are many beneficial topics, and I will just try to contribute to these discussions. And now I will be talking about using technology in symptom management of oncology patients. I will be talking about AI and artificial implementations and applications, and I will be talking about best practices all around the world, and I will be talking about pain and new apparatus developed. Maybe this could just give you some new ideas for a patent. I will start with survivor because after you just have the diagnosis, survivor is defined as a person affected by cancer from the time of diagnosis until the end of life. And many survivors have chronic and exhausting treatment-related side effects that can persist well beyond active treatment, and this could really have a negative impact on life quality, and therefore it's very important to manage all these symptoms, and many of the patients are followed from their homes, so of course we need new treatment mechanisms, and of course COVID pandemic has accelerated these processes, and remote follow-up started, but the pandemic process have accelerated all these processes, and there are a lot of works done in Turkey, especially with mobile applications. We continue to follow up our patients and continue to give treatment. Care planning for each survivor includes the following areas. First of all, the regular follow-up for recurrences or new cancers, management of adverse reactions of physical effects, improving health behaviors and general health care, and also supporting patients to successfully cope with physical or psychological side effects during disease progression and late effects after acute treatment, improving patients' quality of life. Coping with the symptoms of cancer and its treatment is difficult. After clinical treatment and care. For the remainder of the treatment and recovery period, women coping with chronic pain or strong side effects, and failure to adequately treat symptoms leads to decreased compliance with treatment, deterioration of health-related quality of life, increased use of healthcare services, and mortality. Effective care and follow-up are important to reduce emergency room visits, readmissions and hospital stays, and to ensure treatment satisfaction. When we look at the advantages of technology, of course, it's about improving the patient and nurse communication, and advanced symptom and toxicity assessment and management is possible. And of course, the cancer care continuum is also provided, and we could also have optimized patient engagement, and better cancer care and improved quality of life are among the chances. Well, I will be talking about artificial intelligence, because artificial intelligence is an artificial operating system that is expected to exhibit human-specific high cognitive functions or autonomous behaviors such as perception, learning, connecting multiple concepts, thinking, reasoning, or expressing one's opinion, problem solving, communicating, making differences, and decision making. It's all about following up the blood pressure, body temperature. So I will just give you some of the applications from artificial intelligence. And among artificial technology applications in oncology, we have the view, we have data analysis. Some of the applications were done manually, but now you can remotely monitor the patients, and of course proactively managing symptoms and side effects to prevent unnecessary hospitalization, and providing decision support tools for healthcare professionals, improving patient engagement, support, and having access to information. Of course, there could be some individuals who are having difficulties in having access to the hospitals because of the subsistence levels. And of course, you need to have equity in having access to the hospitals, but maybe not every person have access to mobile applications. And we know mobile health applications, and there are many PhD dissertations working on these health applications. We are getting used to it, but of course their implementations are quite important, and these are the results have not yet been converted into positive input. Yes. There could be some mobile applications, but these mobile applications are not integrated to the health system. But and as long as you do not have any integration, then this will be useless. So sustainability is another important issue, and in mobile applications. Data flow is important, but you can have remote access to the information. You could just ask questions. You could just consult about the systems. You could see vital signs, physical activity monitoring. And of course, since many people are going to be using these applications, there could be peer support if you are having any troubles or in using these applications. And also, you have the chance to follow up these patients. Approximately, one of them is about the publication on a study, and in this study approximately 1 in 5 patients hospitalized for ovarian cancer surgery are readmitted to the complications that could have been prevented with follow-up. A web-based application was developed for patients with open bilateral salpingo-pherectomy. And participants were randomly divided into two groups, practice and daily and weekly reminder. If participants reported any symptoms, they answered follow-up questions to understand their severity, and they could just and in this way they could just intervene quickly. You can see the symptoms here to the vaginal bleeding, vomiting are some of the symptoms, and they could just follow up all these symptoms. You can see all the symptoms here, and you could so web-based platforms provide an effective and efficient connection between patients and their healthcare teams, improving adherence to treatment and reducing preventable emergency room visits and hospitalizations. You could see from the symptom care at home, an integrated system monitoring and management system, which is designed to assist cancer patients who receive chemotherapy in outpatient clinics and often experience significant symptoms at home. And there is the warning system, daily symptom monitoring, self-management counseling, warning, and nurses could follow up remotely. When the patients are in the system, the symptom care system patients indicate whether they have experienced any side effects in the last 24 hours. For instance, if a patient notices they have a nausea and vomiting, the system asks them to rate its severity on a scale of 1 to 10. Based on his response or her response, he or she receives automated self-care management counseling tailored to the reported. And we have this system provides real-time 24-hour monitoring and management of chemotherapy toxicity. And also there is the digital thermometer, which is added to the system for following up the body temperature. And also they have tailored evidence-based self-care treatment. They have also yellow and red warning indicators. Yellow is mild to moderate symptoms that can be prevented from progressing with early intervention. Red is chemotherapy emergencies such as neutropenic sepsis. So it is an effective intervention to reduce system burden, improve quality of life, reduce anxiety, and increase self-efficacy during adjuvant chemotherapy. And of course, it is also, this the remote mobile application, they have also taken into consideration patient education about mindfulness, sleep, stress, and nutrition, lifestyle coaching, and of course there are also wearable gadgets which are using. A wearable device is a sensor-enabled device that can collect health-related data remotely. Depending on the device design, it can be worn variously on the wrist, on the upper arm, around the waist, on the hip, or elsewhere on the body, like a wearable t-shirt. Through these apparatus, the vital signs could be followed up, like the blood pressure. So you could just follow your patients at home remotely. You could just continue with your daily routines, but the people working in the hospitals could remotely control your vital signs. These are the heart rates, and average daily steps counts were monitored through the study to identify abnormalities in behavioral patterns that could indicate poor health. And two participants were found to take 1,000 and less steps per day while their heart rate was normal. One of the participants said that he is planning to go to the emergency room due to severe nausea and vomiting. The research team contacted the clinical team and their symptoms were discussed over the phone. His daily step count increased the next day and he resumed normal activities. The second So it's beyond wearable devices now. Sensors embedded or implanted in the body have great potential in the future for monitoring in survivors, which will replace the wearable devices. Well, I will skip some of these slides because they are similar. Patient and provider use of electronic care plans generated from patient-reported outcomes. Through the mobile application, this is a very effective method, and if the person has have some other needs, and in this study the symptoms were rated as moderate to severe. And of course I'd like to talk about pain management and technology, because pain management is very hard for cancer patients, and cancer and its treatments can cause chronic pain at the same time. And of course there are some important gadgets, the tools like QL, and there's electronic stimulations to the fingertips or to the joints. And coil wearable pain relief technology is patented non-invasive nerve stimulation technology that provides relief from chronic pain, and it could be controlled via smartphone, and regular therapy sessions are 60 minutes. These are the TENS glow scrambler therapies. And of course there is the chemotherapy after neuropathic pain. And during the patients with symptoms of chemotherapy-induced peripheral neuropathy for at least 3 months. So this is the scrambler therapy, and it's highly advanced. There are electrodes all around the body, as you can see. And this is the randomized controlled study. And ST or transcutaneous electrical nerve stimulation TENS was applied for 2 weeks. They were monitored for neuropathy for the next 8 weeks. The number of patients with documented improvement of at least 50% based on baseline pain, tingling, and numbness scores was greater in the ST groups, around 36%, ST 56%. And also there is another method used, regional cooling method. Regional cooling is a regional hand and foot cooling system that creates a closed circuit system with large glows covering the hands up to the wrists and socks, covering the feet up to the ankles. There are tubes through which a coolant at 10 Celsius degrees flows through the gloves and socks. This is a randomized study. As you can see here, regional cooling was applied to breast, gynecological, and pancreatic cancer patients receiving weekly chemotherapy starting 13 minutes before chemotherapy and lasting until 16 minutes after. It has been stated that it can prevent chemotherapy-induced peripheral neuropathy symptoms. And of course, there is the psychological dimension of pain management. And another technology, virtual reality, can also serve to reduce the pain of cancer patients by distracting patients through VR goggles. The other study is virtual reality combined with artificial intelligence. Here, 42 women with breast and ovarian cancer participated in this study, and the intervention took place in a virtual reality environment, a winter wonderland called Frosty. Frosty provided both a virtual reality winter experience and guided meditation. The cold winter-like experience is designed to help patients calm down and feel cooler. For this study, patients downloaded apps to their mobile phones, placed the mobile phone in their VR goggles, and then wore them on the hands. Patients were instructed to use the app at home twice a day, morning and evening, and whenever they experienced hot flashes. And this was the interface of the mobile applications. Between pre-intervention and post-intervention, participants improved in the daily hot flashy frequency stress, general physiological distress, quality of life, sleep quality, and perception of illness. Well, in this study, the study explored the potential benefits of virtual reality as a psychological intervention for inducing positive emotions and reducing pain levels in participants receiving level 4 chemotherapy treatment. So the participants felt more calm, relaxed, and happy after VR use, and also felt less nervous. And this is the interface of the implementation application. And this is the cooling system for mucositis. The brain cooling system features a disposable thermostatically controlled intraoral device consisting of closed channels containing continuous water circulation. And the continuous controlled circulation water cools the oral mucosa by reaching a constant temperature of 8 degrees. And this is for cold heading, and especially for losing hair. This is quite beneficial. And of course we have 3D printers because 3D printers are used technologies in the health system and in the nursing area, especially in the simulation applications and material development, personalized anatomical models, prostheses, implants, tissues for transplantation, creating surgical instruments for training and simulation, and you could easily improve the materials and develop the materials, and they are being used in Turkey. As a conclusion, patient-facing digital technologies can help facilitate greater patient engagement in cancer care. However, it is crucial that patients receive appropriate training in the use of technologies, which is digital literacy. Health IT systems can be leveraged to help mitigate the impact of implicit bias in cancer care delivery through real-time monitoring and feedback to clinicians about treatment delays and missed care. And possible disadvantages of technology: there may be privacy, confidentiality violations, it can create extra workforce capacity, it can reduce individual care, and also it may create inequities in access to healthcare. And I think we need to discuss on these subjects as well. Thank you very much for your time. Thank you very much. There's only 5 minutes for discussion. And are there any questions to Ms. Şengül? Yes, Professor Ayten. I'm not against technology, but of course there are advantages and disadvantages of technology. And when we talk about, I have this concern, and I'd like to share this with you. Nursing as a profession, as stated in the previous session, is about the communication. Communication is a sine qua non for the nurses. As long as you are in touch with your patients, that you are being more professional when you get in touch with your patients. Of course, we are talking about VR goggles and some technological developments, but I have this concern. If we use all these technologies, are we just moving away from nursery This is the question because it is very important to touch the individuals spiritually. And of course, I have another concern, or let's say I have another reservation about using this technology. I think these are the products of the consumer culture. Because there is the inequality in opportunity. Who will be able to use these technological tools and who will have this comfort? Well, of course, if we do not lose this touch with the humankind, I think these are complementary, and I think it is very important to touch the spirits of these patients, and because this will be good for the souls of the ones who are taken care of and who are the caregivers. Of course, yes, this is the reality, but of course you could just make use of the existing technologies in our healthcare system. Thank you. Thank you very much. And I'd like to just contribute. Ms. Şengül, thank you very much for your presentation. Of course, technology is limitless. It has a huge potential. And therefore, the young researchers or the researchers in many fields should just develop themselves, improve their information. So I don't think that it is possible, and it leaves no room for improvement without these technologies. And technology is a tool. We are human beings. And therefore, if we are not aware of these technologies and what they mean, it's always risky. The existence of human beings and the creation of human beings themselves is quite important. AI is going to control everything. We are going to lose our occupations, lose our jobs. But of course, the universe is not static. It's ever-changing. So nursing will change as well. It will transform. But what we need to underline is that AI is formed by human intellect. And human intellect, if human intellect did this, this means that we are very different from AI. Yes, of course, we have the physical setting, we have the spirit as well. And therefore, the AI, do we need to be scared of AI or do we need to use it as a tool? I think we need to investigate. But about the sustainability, yes, I do agree with what you've said about sustainability and continuum. And Turkey is developing in these fields, and there are a lot of steps to be taken for the near future. Therefore, if there's no continuum in what we do, if continuity in what we do, is it meaningful? What I believe in is that continuum cannot be easy in Turkey, but this could also contribute to the pool of knowledge. So continuity will continue itself with the future generations. Thank you. Thank you. Let's put all these question marks, then let's produce some answers. Thank you very much for your time.
Oturumumuza ikinci sunum olan kanser hastasının evde semptom.
Now we will continue with the second speech of the second session. Professor Dr. Sevgi Sun will make the presentation.
Herkese merhaba. Çok güzel gidiyor oturumlar. Bu arada çok büyükmüş burası. Buradan
Hello everyone, I would like to welcome you all, and this venue is really large. When standing here, by the way, I realized that just right now, right after Şengül's presentation, I will make a related presentation. We will talk about home care and symptom management at home and challenges in the management of those symptoms. Since 1996, we are talking about home care, and when we had the first workshop, I went to Istanbul to understand what is home care services and realized it was a great thing. But now we in our country, of course, some financial possibilities are affecting the development, improvement of some things, and we are only partially able to do some things, and home care is one of them. But doing it partially is sometimes leading to unsuccessful results. This cannot be done by the nurse or the doctor himself. So, in short, I would like to remind you what is home care, and I will start with definition. Home care service is about the healthcare. It is divided as providing healthcare and follow-up services to individuals in the environment they live with their families by the healthcare team in a way that meets their medical needs, including rehabilitation, physiotherapies, and psychological treatment. And home care service is a process in which many professional healthcare workers provide care together. Why do we need home care? Because the society is aging, there is an increasing age of society, there are chronic diseases and cancers, and chronic diseases, cancers are really important part of this home care requirements. And now the increasing use of technological devices at home, and this is also increasing home care services, and follow-up is also facilitated by these new technologies. And how can we follow up the problems, the patients, and how can we resolve the issues is another issue. And it is a more cost-effective model, and because coming to an institution is something else. Staying there, the cost of the bed is really high. As the cost of institutional care is really high, and home care is becoming more and more important. And patients want to stay at home. They want to receive the care at home. And especially in oncology field, when they're receiving treatment, they want to stay in their homes. They're happier, they're feeling comfortable, they have a higher life quality at their homes. And they are being protected by hospital infection. They are together with their children, they're with their families, and the cancer patients require a long-term care. It is not like a few months treatment and then it is over. It is not like that. Once you are diagnosed with cancer, maybe until you die, there will be some kind of care need. There might be some periods they may need this kind of care. Of course, not all of them are like that. And many applications can be done at home, and it is increasing its application use at home, and widespread use of remote monitoring systems are increasing the use of this service. And it is important to cover all the needs, meet all the needs of the individuals at home. And so we need to define the needs. And there was a study conducted by Polatz et al. And most of the participants wanted home care services to be provided by doctors. And more than half of them wanted home care services to be provided by nurses. So Today we are providing even chemotherapy at home, especially the private hospitals have no boundaries in terms of home care. They're taking blood samples and nutrition feeding at home and the administration of drugs. All of them can be listed under the activities within the framework of home care. What are the needs of cancer patients at home? Pain management. They mostly need pain management. When I was preparing this presentation, I felt lucky, and I said that to my colleagues today. I had another presentation yesterday, and when someone wanted you to make a presentation about the topic, and if you know this topic, if this is a part of your life, I'm not talking about training about this. If it is a part of life, you are making this presentation in an easier way. I started working as an oncological nurse in 1995. So starting from my residency, I was quite interested in oncology, and then God sent me a cancer patient. My father was afflicted with cancer, became cancer, and he died 2 years ago. So when you see this, when you experience this, it doesn't matter whether you're a patient or the family, patient's relative, you start to see the different dimension of this. As the nurses and the health officials, we are at the other side. We are working together with the patient and the families, relatives. But when we see this from first-hand experience, you have different experiences. Of course, I collected many experiences from my father's disease, and I try to collect all the positive aspects of this. I am doing this in all parts of my life. I collect the positive sides and I try to forget the negative sides. Maybe this might be a coping mechanism or protective mechanism, but I did collect the positive sides of all these experiences, and I utilize these experiences in my presentations, in my trainings, and I had the experience of the symptom management personally in my father's case. Pain management. Pain is really important. World Health Organization says that do not cause pain but for your patients. And the cancer patients are generally experiencing chronic pain, and it is said that almost 80% of these patients' pain is not manageable. It is not good for their dignity, and we still have some problems in management of their pain. Why? Because it requires a team. Only a doctor, only a nurse cannot do this, and it should be treated correctly and in a timely manner. And symptom control and management is another issue. Psychological support is indispensable part. It is always important. With the definition of the diagnosis of the patient, the cancer, psychological collapse starts. Sometimes this is also happening for the healthcare officials. Sometimes sympathy turns into empathy, and you are also affected. If you feel sympathy, it is really hard to provide support. If you are acting as a father, children, daughters, as a healthcare official, it is not correct. And pharmaceutical applications, palliative care. Palliative care is really important, especially in the last terminal part. And pharmaceutical applications are important. Chemotherapy support, emergency responses, training of the patients and the relatives, and monitoring and tracking. These are all the important aspects. The management of symptoms are really important. There are textbooks about this, but in this 20 minutes presentation, how much of it can be covered? Most of you already know this. If you are a patient yourselves, or if you have a family, if you have a relative who is a patient, you know it's better. For example, I talked about pain as a symptom. When you are not able to manage pain, life quality is decreasing. They don't want to live. Maybe you have such an experience. Headache, just a simple headache. A severe headache for 3 to 5 days. You don't have any pleasure from living. You don't like what you eat. You don't want to go to work. For example, 4 or 5 years ago during swine flu, I had swine flu and I had a severe headache, and I said that cut my head off please to the doctor. I said it to the doctor. It is really hard to live with pain, and only the management, just by the management of pain, have much difference you can do as nurses. There are different needs of the patients according to their clinical situation, their comorbidities, and our patients receive chemotherapy or radiotherapy, and they experience symptoms affiliated to them. And you know, we cannot give up on chemotherapy, so we will have these symptoms willy-nilly, and one of the most important thing is that symptom control is really important for a nurse, oncological nurse, and we need to know how to manage them, how to realize the symptoms of chemotherapy, radiotherapy. What are the important situations for home care, tips for home care? That we need to have a good communication, we need to know some therapeutic communication methods. If you don't have a good communication, you cannot do anything nice, anything good at home. You need to know the effective use of time. House is different. It is not like hospital. You are making a plan and you have such an advantage. My doctorate thesis was about the home care symptom management, and it was quite effective for me, but it had a positive effect for me. And I wasn't able to do time management in the first days. I was coming to home, but they are quite warm people. They are bringing tea, something to eat, and I need to have 3 visits, but I am spending half an hour drinking tea and talking with them. And in the first week, I was only able to make 1 visit sometimes, and they are very positive. They, this is an advantage of being a woman. They're talking with us, telling many things to me, and this is making everything harder about time management. You should become more professional in this regard. Of course, you should not hurt the feelings of the people who are trying to talk to you, but you need to collect the data. You need to collect as soon as possible, and you need to focus on the management mechanisms that is required for the treatment of that specific patient. So neglecting the needs of family members are reported as the main problems affecting symptom management. So they don't want to go out, they don't have the week, she was a really nice woman, and she didn't want to go to work 6 months. She didn't even have nausea, vomiting, she had breast cancer, and she was receiving CA protocol, but she didn't go to work for 6 months because she didn't have her hair, she lost her hair, so it is really important for her. And there was another younger patient with a single child at the age of 28, 29, and she had a very long, darkest black hair, and of course she lost it all, and she became depressed, and nothing was important. And his communication with her communication with her husband, her child were all negatively affected. For me, it might be another symptom. For primary, there is something else, but for the patient's primary, we need to understand the emotions of the patients. And the literature says that most common symptoms at home in cancer patients are pain, tiredness, nausea, vomiting, loss of appetite, constipation, diarrhea, and mucositis, infection, and susceptibility to infection, being prone to bleeding. And there might be some other neuropathic problems, sleep problems, But the literature says that these are more than others, experience more than others, because these are the side effects of chemotherapy. What about how much time do I have? 5 minutes. Okay, then I will not talk about this part anymore. So you need to detect the symptoms when you go to home in the best way possible, and you should have a good connection with the patient and patient relatives. We should have a ranking. What is the primary? The pain, for example, or some respiratory issue. So these are our priority. The loss of appetite might be another thing, but first we need to manage the pain. We need to make a ranking. If there is a pain relievers, say they might have some opioid phobia, or there are some patients who didn't want to use morphine because of some religious concerns. So we need to think about the situation, our preferences of the patients. I don't want to talk about any more about pain now. We will continue with the fatigue and management. It is because of the suppression. It is happening because of the suppression of the bone marrow, and the patients are always saying that I'm so tired. I cannot chew. I do not have the energy to chew the food in my mouth. And I cannot even move my finger, and we are saying that get up and do daily walks. But if they stay in bed all day, the muscles are negatively affected. So this is important. You need to think about different methods. There are ways of prevention. We don't have time, but we can do something about this. Nausea, vomiting. These are now managed in a better way, and sometimes we are using alternative medicine methods. In the past they were using mint and lemon tea, but now we have different approaches, and you can use them all. You can make a decision about this with the patient, and sometimes if a person do not have appetite, the loss of appetite is an important issue. When you say eat, they feel frustrated, they feel nauseous, and normally they don't eat too much normally during this chemotherapy. So we should not be conflicted with the patient. We have supportive products, supplementary products. They are all adjusted. They have different tastes and flavors, and these supplementary food can be used at the correct time, and it is preventing loss of weight, and it is increasing the life expectation. We do not have to wait for the palliative times. If the patient has already lost 20 kilograms and she or he is not able to drink just a spoon of soup, so then we need to start this kind of supplementary food, and it is also affecting their life quality and life span. I think my time is over. You already know about them, so nothing else. Maybe we can talk during the questions, and my time is up for this presentation. Thank you very much, Sevgi Su, for this great presentation. Any questions or comments? I think we have one question. It's always in the beginning. In the beginning, I spent too much time, but I think the most important things have been mentioned. Thank you very much. It was full of information, but you know, we have a limited time. But this is not just about like contribution. I want to talk about the problem we experience. If they are able to define the symptom, we can manage it. The most important problem is to define it, to diagnose it. There are measurements tools for pain, for nausea. Yes, the pain is important. We have scales of pain, but we don't know how effectively they are filled out. Or we need to make the families accept this. For example, think about a cancer patient, and the family considers for the child to lay down all day, and they, even if you say that he shouldn't lie down like that, they reject this, and they need to define their own symptoms. But there are many different scales, and they want the patients to define their own problems like pain. But the most important thing is to understand how problematic this is for them. The family says that as this patient has received chemotherapy, this isn't quite normal, and so the cancer perception in their mind is like that. They say that they will suffer, they will have pain. Sometimes the child doesn't even talk about these symptoms in order not to cause problems for the families. The adolescents are the most problematic group. They don't tell their pains to the family. And we need to define this, and we need to train the families in this regard, because we are training about the disease, but in order to define the symptoms, it is not quite effective, and training of the healthcare professional is really important. And when you go to the houses, thank you for your question and comment. You are lucky in home care management. Of course, we need competent nurses, and they should know about home care and oncology nursing. And 18 years ago, in Birmingham, in UK, I had a chance to make a visit with another nurse. They were quite advanced when compared with us. They were oncological nurses, and they are a higher rank. They had a higher rank when compared with the other nurses. They receive additional trainings, and we don't have that in our country. And we in home care, many nurses, doctors don't know much about oncology. They are just checking their blood pressure, they do blood, and they give their drugs. But I'm talking about an advanced level, because in oncology patients, the most important problem is home care and home follow-up at home, and we are spending thousands of millions of money, and they come to emergency care for not being able to drink water because they vomit for 3 days. So we should not have this. We should not experience this. The patient is not able to drink water. There is not a follow-up. Maybe they don't know the importance of it. Maybe we're not able to tell the importance of nutrition to the oncological patients, and the treatment is getting worse. And we have cachexia patients. Can you make them live? No. And because we are not giving priority to the nutrition, we are managing vomiting and nausea, but we are not able to manage loss of appetite. And people think that it is normal to be tired, for them to be tired, but it can be overcome. Yes, when their hemoglobin is lower, and they will feel less energetic, and in the first 15 days, but after 15 days they are better. But there are patients who are not even taking off, removing their pajamas, but normally they were better. But there are some patients who doesn't want to go out just because they're afraid of being infected, and they don't know the limits, they don't know their limits. Of course, the patients and their relatives want everything to get better as soon as possible, but the cancer, this diagnosis is a deadly disease, and everything is over for them in their minds. And this is the perception. And home care, if you're a home care nurse and if you have good communication skills, then you get to know each other with the patient and you trust each other. And the patient and the nurse should trust each other. It is really important not to tell lies. We think about each other. You are there for their for doing something good for them. And if your patient knows that you are there for them, then it is not a problem. You know symptom management as an oncological nurse, and when you go home, you can do this. And you can take the patient out of the bed. And I got her a wig once and took her out, and her life, her communication with her child and husband got better. It takes time, but we need to trust each other once we get in the house, and it requires competence and certain abilities. Oncological nurses should be like that. Thank you very much. I want to make a comment. The content of the topic is great. In addition to that, of course, this is a very important topic, and it has legal background. We need to have this in our legislation. It should be supported by the state insurance, and they have Medicare, and it is covered by Medicare. They have a good list about who can take them, who can receive that. It is providing a good support. And of course, it is a group work, and nurses at home 24 hours, so it's us. And the roles of the nurse is important. We should know our roles, and this means that first we should have our own identity, and then we need to improve our role as a nurse, and we need to have pet face care maps. When you call 112 or 911 in US, it takes about 2 to 3 minutes in the United States, but in Turkey it is about 10 minutes. This is a significant problem in terms of home care. And we need to think about emergency action plans. Thank you, Symposium. I want to thank the organizing team for bringing me before you. Thank you very much.
Semptom yönetimi oturumumuzun son sunumu olan telesağlık ve onkoloji hastasının ev.
The last presentation is from Nihan Özkan Güler on telehealth and home triage of oncology patients, a single center study. We would like to invite her to the floor. Distinguished participants, I'd like to welcome you all. As Sevgisun and Şengül mentioned, and there are many professionals coming together for giving healthcare services, and of course, this is quite important for the patients and patient relatives. And as LÖSANTE Lösev, I'd like to present you my research. Telehealth and home triage of oncology patients. And telehealth is defined as the provision of healthcare information and education remotely through the use of various telecommunication tools. The American Nurses Association in 1992 recognized nursing informatics expertise as its field of expertise and initiated telenursing practices, and in 1999 defined the basic principles and the competencies of telenurses in 1999. The first home telehealth teleguide clinical guidelines were developed by the American Telehealth Association in 1998 and updated in 2003. The regulation on the provision of remote health services, published by the Ministry of Health on February 10, 2022 in our country, the procedures and principles of telehealth were defined and the necessity of providing health services regardless of location and geography was emphasized. The increasing cost of healthcare services in hospitals, the continuing need for care after the individual is discharged, and the emergence of various additional healthcare needs due to the aging along with the aging of the society lead to an increase in home healthcare services. Nowadays, especially with the pandemic, in telenursing practices, triage is performed, especially by phone, in order to evaluate the health status of patients and determine their care and needs. This has become widespread. In this study, it was aimed to evaluate and manage the symptoms developing after treatment in patients who underwent chemotherapy in LÖSANTE Children's and Adult Hospital, Adult Oncology Outpatients Clinics with telehealth application. Volunteer patients who were followed up in the LÖSANTE Children's and Adult Hospital Outpatient Adult Oncology Hematology Outpatient Clinics and received chemotherapy between April 2022 and January 2023 were included in the cross-sectional study. The patients who applied between these days were called by the oncology case nurse after the treatment and their symptoms were questioned. Information received from the patient, Adult Oncology Hematology Patient Evaluation Form, these were recorded. The patients included in the study were first asked about their demographic characteristics, place of residence, and year of diagnosis. The symptoms experienced by the patients were questioned and recorded in the data form. Visual pain scale was used. Data obtained from the statistical package for the it was analyzed with statistical package for and numerical data given as mean and standard deviation, and categorical data were given as numbers and frequency. Chi-square test was used. Significance level P 0.05 was considered significant. Between 2023 and 2023, 3,310 applications were made to the adult oncology patients clinics of our hospital. When duplicate applications were removed, it was determined that 159 of the remaining 603 patients received only chemotherapy treatment. The study was conducted on these 159 patients. 64.8% of the patients were female, 35% were male. The average median age of the patients was 61 plus minus 12 years. The average age in women is 60 plus minus 13. In men it was 63.5 plus 9 minus 9. General distribution of the patients according to the age, to the gender. As you can see here, 66% of the patients were in the first year of the disease. 21 were in 1 and 5 years, and 11 were in 5 years or more. While 64% of the patients lived in Ankara, 35% lived in other provinces. So distribution of symptoms seen in patients after treatment. 66% is fatigue. And nausea, 32, pain, 32. These are the most common symptoms. And distribution of pain levels and pain areas, according to us, when we look at the pain zones, it's mainly mouth, bones, joints, headaches, backaches, stomach aches. and the average liquid intake is 2-3 liters 36, 1-2 liter 45, less than 1 liter 17. Mucositis, nutritional problems, feeding problem, and 6.2 suffered from vomiting, 60 point from nausea. And patients with fatigue stated that they received support while doing their own work. And comparison of post-treatment symptoms by gender. Males had more fever, and women had loss of hair mostly. Consultancy and guidance for the patients, and those who complained of pain, nausea, vomiting, diarrhea, and constipation were referred to their doctors, and drug treatment was started. Patients with fever were directed to our hospital's emergency department and evaluated for signs of infection. Catheters were given catheter care training again. Mucositis patients experiencing problems were given training on oral care. Patients with hair loss were told that their hair loss would return to normal after treatment and were given emotional support. Since the majority of these patients were women, an opinion was made that they could use an alternative method. It was determined that 10 patients, 6.2, with decreased fluid intake, malnutrition, and weight loss were given home support treatment in consultation with their doctors. Telehealth was used before the COVID pandemic. It has become a feasible and safe alternative during the pandemic that increases access to patient care, prevents delays in treatment, and reduces the risk of patients being exposed to SARS-CoV-2 infection. According to the results of the studies of the telehealth applications, remote technology supported interviews contribute to the evaluation of individual preferences and priorities and the management of difficult processes in terms of a patient-centered approach. Rob and friends in a study comparing telehealth and outpatient clinic visits and follow-up in multiple sclerosis patients, the feasibility of telehealth was demonstrated due to its convenience and similarity in clinic visits. In the study, 97% of the participants reported they could recommend telehealth visits. Telehealth applications are implemented in some centers as a part of ongoing health services for cancer patients, and there are a wide variety of applications such as teleconsultation, telepathology, teleeducation, and multidisciplinary teletumor board where case discussions are held. Telehealth application for oncology patients receiving chemotherapy. It's a positive application for the management of symptoms in patients without having to come to the hospital environment by ensuring the continuity of nurse-patient-doctor communication. In addition to patients requiring medical support, the possibility of follow-up and treatment from home also has positive effects on the quality of life, the care burden of the patient's relatives, and the cost. It also enables follow-up of the patients not only in the city but also from outside the city. Thank you very much for your time. We are planning to do so together with Dr. Didam. We are planning some future studies. Well, I cannot hear the person asking the question. Interpreter's note. Thank you very much for your presentation and research. Well, of course, I don't think that there's a hospital giving this healthcare services via telecommunication tools. Of course, we would like to do so. And when you are giving your conclusions, of course, you have shown us how many people suffered from pain and how you have managed the symptoms. And of course, you need to show the effectiveness of this telehealth applications and the outputs of these applications. This is very important. How frequently you were calling your patients? We were calling our patients on a monthly basis. For maybe on a regular basis, like a daily or weekly, or yes, we have received complaints from our patients. The numbers are this, and with telecalls and with phone calls, we could be able to manage the pain, or maybe we could just stop the weight loss of these patients. Maybe you could have given the data on your on your application. Thank you very much. We are ending our session. Those who come from outside our institution to present them with their certificates. And with the certificates, and of course our steering committee will give will plant the seeds. We'll plant the seeds of trees to the Lösev Seferihisar Nature Ranch.
kontrol. Deneme 1, 2, 3. Alo. Alo. Ses kontrol. Ses kontrol. Deneme 1, 2, 3. Deneme 1, 2, 3. Prova. Ses kontrol. Ses kontrol. Deneme 1, 2, 3. Alo. Deneme 1, 2, 3. Bende. Tamam. Ses kontrol. Deneme 1, 2, 3. Bilgisayar sesi hangisi abi? Onu işte ben hatırlamıyorum.
29-30. Ses deneme 1, 2. Sesim geliyor mu?
29-30. Evet,
kapalı şu an.
Ses gelmiyor ama açtım. Açamadım, açtım.
Tercümanların sesini bir tık da arttırabilir miyiz Ufuk abi?
Efendim?
Ses. Tercümanların.
Ha, direkt bağlantıyı direkt sağlamışlar. Oradan deneme yapıyorlarmış.
Ses deneme 1, 2.
Bu canlı
Ses
bağlantıyı
deneme
deniyorlarmış.
Diğeri yaka mikrofonundan konuşuyorlar. O nasıl? Yakayı bir tık daha arttıralım diyorlar.
Bu kullanılmayacak zaten de deneme için açmıştık. Evet.
Tamamdır.
Şimdi canlı bağlantının kendisini sağladılar. Bir onu deneyelim önce.
Tamam. Evet. Uzun da bağlanıyor. Ben bir de kürsüden konuşayım. Yakın konuşacağım şimdi.
Yes. Yes, of course. Pardon?
Say.
Miss Colina, could you please just
Ses deneme 1, 2.
say something for the voice?
I'm sorry, there is a lot of echo on my side. I echo you and myself.
Say something again. We just
Şu an cevap vereceğim ben size.
reorganize the voice.
Is it okay?
I think little. Yeah, the presentation it seems